So in the last chapter, we talked about cerebrospinal fluid and its protective and nutritive functions with the brain and some disorders associated with it. The other support system that's critical for brain function is the blood supply. So the blood needs to have a continuous supply of good quality oxygen and nutrients coming into it at all times. So just like in pathophysiology when we talked about the cerebral arteries supplying the heart, the coronary arteries supplying the heart, the cerebral arteries supply the brain. And so any interruption in the supply can cause problems. So for the learning objectives, I really want you to focus mostly on the disorders we're going to be talking about. I want you to be able to define a transient ischemic attack, or a TIA, and how it differs from a CVA. I want you to be able to identify characteristic stroke signs by arterial location. So a lot of strokes have some similar symptoms across the board that you will encounter, but each of the major arterial locations has one sign that distinguishes it from another. So I want you to pay attention to particular distinguishing signs, and I will point them out as we talk about them. There's also, as you will not be surprised to find out, a chart in the module that links the artery with its distinguishing sign. So loss of blood supply in a specific area correlates with specific loss of function. In the book, they talk a lot about the different blood supply, or the structure and the anatomy of the blood supply, and we're not going to talk much about that. But just know that if we lose blood in a specific area, we're going to have a specific loss of function. So disorders of the vascular supply are classified according to both the pattern and progression and the cause of the, so is it ischemic, is it hemorrhagic, that sort of thing. A transient ischemic attack, or TIA, so transient, it's brief and it doesn't last. Ischemic, you're losing the blood supply, and attack is obvious. So it's a brief focal loss of brain function because it's a brief focal loss of blood supply with full recovery from neurological deficits within 24 hours. So if you work in acute care, a lot of times you'll see people admitted to the hospital, and the admitting diagnosis will be TIA versus CVA. So they're trying to distinguish, has the person had a stroke or CVA, or is it a transient ischemic attack? So as we talked about in pathophysiology, a transient ischemic event in the heart, in the coronary arteries, causes angina. Because we lose that blood supply, it causes some transient chest pain. And then you get full recovery, either treated with medication or on its own. And if you have full ischemia that causes death of heart cells, then that's a myocardial infarction. So that's directly analogous to a TIA and a CVA. So the transient ischemia, which causes brief focal loss of function, is a TIA, and then the ischemia that causes death of the cells is a CVA. And just like with the coronary equivalent, the cerebral equivalent, if someone has repeated TIAs, it's probably leading up to a CVA. If someone has repeated angina, it may be leading up to a myocardial infarction. So it's similar, it's analogous, directly analogous. So a cerebrovascular accident, or CVA, is a stroke. Some members of the medical community are advocating the name brain attack as a layman's term to replace stroke, to emphasize that prompt treatment may benefit some people who have stroke, just like prompt treatment is effective for some people who have heart attacks. There didn't used to be acute treatments for strokes. Like in the 80s, when I worked on the ambulance, if someone was having a stroke, they would just admit them to the hospital and monitor their vital signs. There wasn't much they could do. But now there's surgery that can be done. There are drugs that can use to break up a clot. And the earlier someone gets treatment, the less effects that they're going to have that are lingering, hopefully. So when we talked about how it's classified by progression, a completed stroke is neurological deficits from vascular disorders that persist more than a day, so it's not transient, but they're stable, they're not changing. A progressive stroke is deficits that increase intermittently over time. So completed versus progressive. A brain infarction, just like a myocardial infarction, occurs when an embolus or thrombus lodges in a vessel, obstructing the blood flow. Typically, the embolus abruptly deprives the area of blood, resulting in an almost immediate onset of deficits. So 1 second the person's fine, and the next second they're having problems. Obstructions of blood flow in small, deep arteries result in lacunar infarcts. Slow occlusion of an artery has a different outcome than an abrupt occlusion. So the slow occlusion of an artery is like arterial disease, happens over time, and abrupt occlusion usually results in immediate cell death. Hemorrhages, when there's a hemorrhage, the downstream vessels are deprived of blood, and the extravascular blood exerts pressure on the surrounding brain. So generally a hemorrhagic stroke results in worse deficits within the hours of onset, but then improvement occurs as the edema decreases and the extravascular blood is removed. So it appears at the beginning that there are worse deficits, but then as the edema subsides, you regain some function. With a subarachnoid hemorrhage, it usually causes a sudden excruciating headache with a brief loss of consciousness. When they say initial findings are often not focal, a lot of times the hemorrhage spreads throughout the subarachnoid space. Deficits tend to be progressive because of the continued bleeding or secondary hydrocephalus. Vasospasm and infarction are common sequelae to a subarachnoid hemorrhage. So the signs and symptoms of stroke depend on the location and the size of the lesion. Each of the deficits that are listed here has been reported to affect more than 25% of people surviving brain infarctions. So hemiparesis, so that's partial loss of motor control on one side of the body. Ataxia, incoordination. Hemianopia, that's the where half of your visual field is missing, whether it's bitemporal or homonymous. Visual perceptual deficits. Aphasia, which is difficulty speaking. Dysarthria, which is a different kind of difficulty speaking, and we'll talk about that in one of the upcoming chapters. Sensory deficits, memory deficits, or problems with bladder control. So any of those can be signs and symptoms of stroke, but then there are some specific signs that are associated with individual locations. So many of the stroke signs by arterial location may involve the main artery, smaller branches, and capillary network, or the arteriovenous formations. So once the main artery is blocked, everything downstream can have problems. So a vertebral or basilar artery stroke, 20% of ischemic strokes affect the brainstem and cerebellar regions. So the vertebral and basilar arteries supply the brainstem and cerebellar regions. So do you think it's normal that we're going to have some brainstem and cerebellar symptoms, signs and symptoms? Absolutely. So the chief symptom of vertebral artery dissection is pain, usually in the posterior neck or occiput and spreading to the shoulders. With vertebrobasilar artery ischemia, the most common signs are gait and limb ataxia, so that's a cerebellar sign. Really makes sense, right? Limb weakness, oculomotor palsies, and oropharyngeal dysfunction. So brainstem, oculomotor, and oropharyngeal, those are cranial nerves. So we're seeing brainstem signs with this particular artery. The most common symptom in acute cerebellar infarction are dizziness or vertigo and an inability to sit upright without support, difficulty walking, nausea and vomiting, dysarthria, and headache. So that vestibular tie-in, that ties into the vestibulocerebellar area. Complete occlusion of the basilar artery causes death as a result of ischemia to brainstem nuclei and tracts that include control vital functions. So vertebral and basilar artery, think vestibular and brainstem symptoms. So when we get into the cerebral arteries, the incidence of ischemic stroke affecting different arteries, look at that big red area. 69% of ischemic strokes affect the middle cerebral artery. So the symptoms that we generally associate with stroke tend to be middle cerebral artery symptoms. Only 2% affect anterior cerebral artery, and then you can see the smaller other percentages. So by and large, the middle cerebral artery is one of the most affected arteries with ischemic strokes. And so those are the MCA stroke symptoms are the ones that we generally think of as your classic stroke symptoms. So strokes affecting the anterior cerebral artery affect personality. With you still have the contralateral hemiplegia and hemisensory loss like the other strokes have, but the personality changes. That's what's really important, because the frontal lobe, the anterior cerebral artery, affects the frontal lobe, and that's the area that controls personality. So lack of blood supply to the deep branches of the anterior cerebral artery also results in motor dysfunction caused by damage to that the motor areas in the frontal lobe. So when you think frontal lobe, the anterior frontal lobe, remember the decision to do a motor act happens there. And then personality. So personality changes and motor dysfunction. Those are the cardinal signs of anterior cerebral artery stroke. The middle cerebral artery, it deprives the optic radiation and lateral parts of the sensory motor cortex and adjacent white matter of blood. So the symptoms often include homonymous hemianopia combined with contralateral hemiplegia and hemisensory loss involving the upper limb and face. So that homonymous hemianopia, which is like a visual field cut, that is a cardinal sign of middle cerebral artery stroke. Also, the contralateral hemiplegia affecting the upper and lower extremities and the face, as well as aphasia. So aphasia is one of the cardinal signs of MCA stroke as well. And difficulty understanding spatial relationships, spatial neglect, and impairment of nonverbal communication often occur. So those are kind of the contralateral hemiplegia and hemisensory loss, and the aphasia and neglect. Those are sort of the classic stroke symptoms that we often see, and it's because 69% of ischemic strokes affect the middle cerebral artery. The posterior cerebral artery cause eye movement paresis or paralysis, and it affects the muscles innervated by the oculomotor nerve. Strokes affecting the branch that gives blood supply to the occipital lobe near the visual cortex cause cortical blindness. So posterior cerebral artery, think cortical blindness, because the occiput is in the posterior part of the brain. Lack of blood flow to the thalamus can also cause problems with thalamic processing, but the cortical blindness is the cardinal sign for posterior cerebral artery strokes. So sometimes you get developmental abnormalities occurring where the arteries connect to the vein. Instead of having the normal capillary beds, you have abnormal thin-walled vessels that are larger than capillaries. And they're called arteriovenous malformations. Or it's really the formation. So you can go along your whole life with arteriovenous malformations with no signs or symptoms unless they rupture. So when they rupture, bleeding causes dysfunction as a result of lack of blood to the downstream area and pressure exerted by the extravascular blood. So when arteriovenous malformations rupture, they cause hemorrhagic strokes. And typically the signs are worse at the beginning, and then as if the person lives, as the pressure subsides, the symptoms become less pronounced. So an aneurysm is the dilation of the wall of an artery or vein. The swelling has thin walls that are prone to rupture. So saccular aneurysms are the most common, affecting only one side of the vessel wall. A berry aneurysm is a small sac that protrudes from a cerebral artery and has a thin connection with the artery. So you can see what the problems would be there. Potential for more clot formation, and because the walls are thin, potential for rupture. So an aneurysm could cause an ischemic stroke or a hemorrhagic stroke. The blood-brain barrier, which we've talked about briefly before, it's a specialized permeability barrier between the capillary endothelium of the central nervous system and the extracellular space. And it's formed by tight junctions between the capillary endothelial cells that exclude large molecules like medications and neurotransmitters and a lot of other things. The exclusion is useful for preventing pathogens from entering the central nervous system. It also prevents certain drugs and protein antibodies from accessing the brain. So the blood-brain barrier is absent in areas of the brain that directly sample the contents of the blood or directly secrete things into the bloodstream. So parts of the hypothalamus and other specialized areas around the third and fourth ventricles, it's sort of leaky. It's considered a leaky region of the blood-brain barrier because the hypothalamus has to directly sample the contents of the blood for oxygen and CO2 level and other chemical levels, and also it has to secrete hormones into the bloodstream to control different body systems in homeostasis. So there are specialized cells that are called tanocytes that separate the leaky regions from the rest of the brain, and these cells prevent proteins, viruses, and some drugs from entering the brain via the leaky region. So they're sort of like little protectors. It's sort of like they're the guy that's standing next to the cones to keep people from going into where it's dangerous. So oxygen consumption increases from the brainstem to the cerebral cortex. Makes sense, right? The cerebral cortex needs a lot of oxygen. So the cortex is more vulnerable to hypoxia than the vital centers in the lower brainstem. The cerebral arteries auto-regulate local blood flow, primarily depending on blood pressure and metabolites. So the autoregulation is vitally important to ensure adequate blood flow and prevent brain edema. So it doesn't matter if you're standing on your head, your cerebral arteries are still regulating blood flow. You're not getting any more blood to your brain because we want to make sure that the blood flow is adequate but not too much. So cerebral edema is the accumulation of excess tissue fluid in the brain. So causes of cerebral edema can include concussion, which is basically a mild traumatic brain injury, because a concussion allows fluids to leak from damaged capillaries. Cardiac arrest can cause cerebral edema. High altitude, so fluid pressure results in ischemia, causing arterioles to dilate and increasing the capillary pressure, producing more edema. Edema can be alleviated by shunts or medications, or in case of high altitude, the treatment is to move to lower altitude. So not as cerebral edema can also have life-threatening symptoms. So cerebral edema, hydrocephalus, tumors, and other lesions can increase intracranial pressure. The symptoms of any of those things, including cerebral edema, are vomiting, nausea, headache, drowsiness, frontal lobe gait ataxia, and visual and eye movement problems. Lesions may produce a herniation in part of the brain. So blood flow to the brain, they can look at it using a PET scan, which is kind of cool, or angiography. And so this is an image of a PET scan. It's a computer-generated image based on the metabolism of injected radioactively labeled substances. Angiography uses an injected radio-opaque dye, followed by a sequence of X-ray images. So they can actually look at cerebral blood flow. There's some really cool images in the book, and you can find images online of these type of imaging processes. The venous system, the major venous system of the brain consists of cerebral veins. The veins drain into dural sinuses and the internal jugular vein. There are two sets of veins that drain the cerebrum, superficial and deep. So you don't really need to know the detail on that, but we get the blood in and then we have to drain it back out, right? Okay, so in the next section we're going to talk about the cerebrum, and we'll talk more about stroke.